And good afternoon, our respected teachers and my dear colleagues. So, I am here to present my topic, the role of oral sodium bicarbonate in patients with early stages of CKD with Eubicarbonatemia. And I am from Government Medical College, Calicut. So, background, and we know that there are well-established studies in hypocarbonatemic metabolic acidosis, but the problem is that even with the Eubicarbonatemia, there is intracellular acidosis. So, we need to tackle this also. And there are two concepts are there. So one was a classical and followed by an expanded concept. In expanded concept, it is said that so there will be H plus retention even when the bicarbonate is within the normal range. So with the CKD, first there will be an adaptive response and followed by a maladaptive response which causes the CKD progression. So our evidence was in animal studies, this oral soda bicarbonate, it reduced the urinary levels of endothelin-1, angiotensinogen and aldosterone, especially in patients with CKD stage 2 compared with CKD stage 1. So my primary objective was to study the effect of oral sodium bicarbonate in patients with early stages of CKD, that is 2, 3A and 3B with Eubicarbonatemia, and its effect on urinary citrate, then urinary angiotensinogen creatinine and urinary endothelin 1 creatinine ratio. And my secondary objective was the correlation of the above with the urinary ACR and EGFR at the study exit. So this was a 1-year prospective randomized control trial, and randomization was done with a block with an allocation ratio of 1:1. And I included patients with a CKD stage 2, 3A and 3B, means with a Eubicarbonatemia, that is from the bicarbonate 22 to 28 milliequivalents per liter. And I excluded patients who had a contraindications for this oral soda bicarbonate. So these were the outcome measures. So we had this urinary citrate, urinary angiotensinogen creatinine and urinary endothelin by creatinine. And the secondary measures were the albumin creatinine ratio and the EGFR. And urinary citrate was assessed by the colorimetry method and urinary angiotensinogen and endothelin by the ELISA. And we used appropriate statistical methods for both the qualitative and quantitative variables, and we had so many variables, so we even did a regression analysis also. And the sample size, we had this 27 patients in the control arm and 27 patients in the intervention arm. So apart from the baseline test, and we did this albumin creatinine ratio, then this urinary citrate, urinary endothelin and urinary angiotensin, both at the study entry and study exit. And in the control arm, we gave standard treatment for all patients, and including for management of this hypertension, diabetes with ACE inhibitor or ARB or SGLT2 inhibitors. And in the intervention arm, and they were given, along with the standard treatment, they were given this soda bicarbonate also. And it was given at a dose of 0.5 milliequivalents per kilogram body weight, and it has to be taken some 2 to 3 times per day and along with the food. And in the control arm, and there was no soda bicarbonate. And this soda bicarbonate had some side effect also, and these were clearly explained to the patients, and they were asked to monitor the symptoms also. And if they develop any symptoms in a distressing manner, they were asked to report to the hospital, or a teleconsultation was done. And it was a 1-year follow-up study. So we did a bi-weekly BP, potassium, calcium and sodium, and monthly ABG was done to keep the bicarbonate at a level of less than 32 milliequivalents per liter and a pH of less than 7.4, and weight was also monitored monthly. And we have a chart for this side effect profile. So in the analysis, so this is the consort diagram where so there was no follow-up, and we analyzed all the 54 patients. So coming to the results, so in the general results, in the general results, the age, systolic BP, diastolic BP, and the BMI was comparable at the initial in both the intervention arm and the standard arm. And the most common cause of etiology of my study was this diabetic kidney disease. And baseline parameters were also comparable in the intervention arm and the control arm. And the most common stage was stage 2 followed by 3A and followed by 3B. And most of the patients were in the RAS inhibitors or this SGLT2 inhibitors, because most of the patients were having diabetic kidney disease. And this is a chart showing the mean monthly serum potassium and bicarbonate. So serum potassium was between the range of 3 to 5.5, and the bicarbonate, it was in the range of, over 1 year, it was in the range of 24 to 30 milligallons per liter, and in the intervention arm, and in the control arm, it was in the range of 22 to 26. So it was a high in the intervention arm. So because of our drug. Then the arterial pH at the, in the intervention arm, at the end of study, it was around 7.34 mean, and in the control arm, it was 7.28. Then coming to the actually primary outcome measures, so we have, we had these actually 3 markers. So the first one was a urinary citrate, and at 12 months, the urinary citrate was increased in the intervention arm when compared to the control arm, and it was statistically significant. Then the second marker, it was a urinary endothelin bar creatinine ratio. Here, it also actually decreased at the end of 12 months in the intervention arm when compared to the control arm, and it was statistically significant. And the third marker was a urinary angiotensinogen bar creatinine ratio. It was also decreased at the end of study in the intervention arm. Then we did an ANOVA to find the association between the oral bicarbonate supplementation, and there was an association between oral bicarbonate supplementation with urinary citrate and endothelin in the intervention arm. It was not seen with the urinary angiotensinogen bar creatinine ratio. Then moving on to the secondary measures. So secondary measures, we wanted to know the association with the, so we wanted to study the correlation of this urinary citrate, endothelin angiotensinogen with eGFR and urinary ACR. In the intervention arm, there was a correlation between urinary endothelin with eGFR and urine ACR at 12 months. But in the control arm, it was no correlation. Then coming to the urine ACR, intervention arm had no significant change in the proteinuria. At the start of study, the intervention arm, the proteinuria was around 72 urine ACR, and at the end, it was actually 77, and it was not statistically significant also. Then coming to the comparison of the eGFR, here there was a significant increase in the eGFR in the intervention arm at the study exit, and at the onset, it was around 66 ml per minute, and at the end of study, it was 74 ml per minute. Then finally, and we did a multiple linear regression analysis because there were a lot of confounding drugs were there, like ACE inhibitors and this SGLT2 inhibitors. So in the regression analysis, it was, so this oral soda bicarbonate supplementation, it was positively associated with urinary citrate and eGFR. Means with the supplementation, there was increase in urinary citrate and eGFR, and there was an inverse association with urinary endothelin creatinine ratio. Means with supplementation, there was a decrease in the urinary endothelin creatinine ratio. And so this is the final result. So coming to the adverse effect, and there were not much serious adverse effect was seen, and actually none of them was statistically significant also. And the most worrying, actually worrying in this adverse effect, which is explained in actually literature, is a worsening hypertension, and which was seen in actually none of the patients. And drug compliance was also good. So coming to the comparison with other studies, and there are, we know that actually there are well conducted multiple RCTs are there in this soda bicarbonate in advanced CKD, that is from stage 3 onwards, and among these it is a UB study, base pilot study, etc. In actually majority of the study, they included patients with a bicarbonate less than actually 24. So coming to the conclusion, so first one is urinary angiotensinogen and urinary endothelin, they were reduced, and urinary citrate was increased with oral bicarbonate supplementation, and there is an association between oral bicarbonate supplementation with urinary citrate and endothelin, and there was a negative correlation between urinary endothelin and eGFR at the exit. So oral soda bicarbonate in Eubicarbonatemia early CKD, it is associated with improvement in eGFR. This is my final conclusion, and this is again actually slide showing the results in a simpler way. Oral bicarbonate in eubicarbonatic metabolic acidosis. So here the urinary citrate was increased. So there was a reduction in the urinary endothelin, and there was a reduction in the urinary angiotensinogen, improvement in eGFR, So there was no worsening of proteinuria or worsening hypertension, and there were not many side effects. So the strength of our study is that it is actually one of the first kind of study to supplement the oral soda bicarbonate in early stages of CKD with Eubicarbonatemia. And soda bicarbonate being cheap, easily affordable, and with good compliance and with minimal side effect, it is attractive drug even in early stages of CKD. And limitation, it is a actually single center study with less sample size, and urinary ammonium was the best measure of this intracellular acidosis due to technical issues, and we couldn't do this actually urinary ammonium. It is very costly, plus it is very actually cumbersome.